really well too. So first is, I don't have any disclosures, relevant disclosures. As far as objectives to go, is I think the big picture is want to appreciate that substance use disorder in general is met with a lot of misunderstanding by people, by our society, by our culture, and without getting into all the history on to why that is in detail. There's a lot. I know growing up, and giving one example is the Just Say No campaign or the DARE campaign, that drugs are bad, people who do drugs are bad people, was what I was taught, what I learned. And I think we know that isn't the case. So in this talk, we're going to talk about why some of those stigma occurs, and how evident that it is in clinical studies, and try to create some barriers to us being able to communicate with our patients better, and ultimately to promote recovery and long-term solution for our patients. I'm going to also try to multitask and monitor the chat as well. So I think the first basis, and this was really the aim of NIDA, or the National Institute on Drug Abuse, of drug abuse, in the 1980s and really into the 1990s, and demonstrating the chronic changes that undergo the human brain in people with substance use disorder compared to those without, and to demonstrating that there really are fundamental changes that happen in the brain. I always like to say that, this was a tool that was given to me in trying to help understand discrimination in the workplace. And I recognize that it's a very basic concept, but just start replacing one disease, or instead of how would I treat somebody if they were African American or Native American, would I say the same thing? Would I say the same thing about providing an evaluation of a woman as I would a male rotator? I think, would I treat this differently if this was hypertension, diabetes, cancer, that I would as opposed to a substance use disorder? And that's kind of helped me kind of recognize some of these things that we talk about. So I think of the conditions that we treat, the most substance use is probably the most stigmatized. I also, the only other thing that I can really think of in my clinical practice that had the stigma related to it was the HIV/AIDS epidemic back in the 80s and the 90s. And we've got stuff where like Magic Johnson playing on the American basketball on our dream team, the Australians didn't want to take the court because he was going to be on there, and you look at him. And again, we look back and how different times were, how many different movies that have been nominated for or won Academy Awards for dealing with the stigma associated with HIV/AIDS epidemic, and how bad that has been for people. Jordan, could you mind just, if they call back, just tell them that I'm in a lecture? It's the same number from Texas. I don't recognize it. I'm sorry. I'm also on call for the Poison Center today, which, by the way, is actually a good thing for y'all, because the Poison Center, we're free. We don't cost any money. And thanks to Julie and a SOAR grant that we have, we also take addiction call. The only two things with an addiction that we can't do is write prescriptions for meds for the patients and refer a patient into and link them directly to care. But if you have any medical questions, day or night, give us a call. We don't charge you, we don't charge the public, and that's fine. Also, your patients are welcome to give us a call too. So just put in a plug for how to utilize your tax dollars. So this is a study from Barry et al., and it was a survey, and just looking at, now, I always hate people who read word for word off their slides. So I'm just going to have a brief pause and just let you look at some of the outcomes where they looked at on how, and essentially, I think it's obvious when you read it. So I'm just going to be quiet for a second. So I think when we look at this, I think we, first is understanding differences. We need to turn the perspective internally on us and to say is that I'm probably in that majority of patients, or I'm sorry, not patients, but of human beings or people in our society or in our culture who probably doesn't view people with a substance use disorder or even a mental illness as like we would other people. And is that really the right thing to do? I think in your personal life, I'll let you make those determinations. But I think in your professional life, we have taken an oath to treat our patients, and we have a moral obligation to try to help with this. I think the stigma within healthcare providers is definitely there. There's perceived with violence, manipulation, poor motivation on delivering of care, and I think that's part of also why in getting people with a substance use disorder to engage in treatment and to trust the medical system also becomes important. This is also one of these slides that I think is just kind of fun to do and be a little bit more interactive. So I want you all to read this and then to start commenting in the chat box. My rotators and people who are more vocal, feel free to speak up and just say what some of the stigmatizing language is. I want to just thank all the people like Athena and Terry who did a really nice job putting multiple comments in here. And I would also put in there that really the insisting that the patient detox, and just kind of the term detox is a little bit on the stigmatizing, is that we want to, great one on getting clean. That one's a pet peeve of mine. One of the things that I love doing is studying religions around the world. The major three monotheistic religions, Christianity, Judaism, and Muslim, and clean and dirty are fundamental to us as Christians. We call it the Old Testament, but the Hebrew Bible, the first couple of books, and especially Leviticus, but all that's also duplicated in the Quran too. So very fundamental on when we're using clean and dirty to refer to people to in Western society. And then also with the detox is we want to engage people into treatment, and how would we be responding should the person have like any other chronic disease like diabetes, hypertension. And I think what's highlighted here in red is kind of what I want to say is the traditional approach. This is a substance abuser. It's their fault. They can help it. It's their willpower. They just need to suck it up. They need to do more. As opposed, and a better mindset is, look, I've got tools available. We've got evidence, not only evidence-based tools, but that are approved by the FDA, but the evidence is so compelling for survival benefit and as far as health outcomes that we really don't have much else in medicine that's even in this arena, and that we should be, how can we help move this patient along? And one of my favorite examples to always do in teaching is asking the smoker, do you smoke? And they say, no, I quit. And you do in the follow-up question, when did you quit? And they said, yesterday. And we all just kind of laugh. What's the patient doing is what they're saying is, look, I know I need to quit, but I just don't want the lecture on it. And so why I handle that in the addiction clinic is like, that's great, you quit. I know quitting smoking is like one of the hardest things to do. What can I do to help support you through that? And would you be interested in talking about it? And always change it, very rapidly changes the mindset. And they will answer is, no, I got this. I can do it again. And then be like, great. If anything changes, I'm here for you. And then I move on with the rest of why I'm there to talk to them, because in the ER, they're in there with their injury or their bump or their cold or why they came, and they don't want to be sidetracked with their smoking, and they're just not ready to quit. Same thing that happened with opioids, as well as stimulants. And I think it's a more change in the mindset. How can I help? How can I bring these treatment options to our patients? Also recognizing that people with a substance use disorder, they're oftentimes not in a good place mentally. They know they shouldn't use, and they themselves feel and oftentimes are convinced that they're a bad person or bad human being simply because they're using, and because they don't have control over their own substance use disorder. And so when we come down on them hard for still using, their natural defense mechanism is to use again, and to recognize that we might be trying to trigger that. As an ER physician, I still struggle with the acronym that Susan brought up of MI, because I think MI was taken by the cardiologist. But this is exactly into the motivational interviewing, which is what Susan had meant it to be. And that's a whole area of science on how to work constructively to bring people in and be ready to change and to move forward. I think as a transition point, is really, this is what our patients are thinking, that we in healthcare, we're kind of at times, and a lot of our time doesn't feel like we're on a pedestal, but I think when a lot of people in society do look for us and to be a bit of a leader or to help them with their healthcare, and if we label them as an addict or a user, and we tell them that they don't have power or control over it, and that they're weak, that the person really becomes convinced in their own mind that they can't change and that they're stuck. And it moves us backwards on that motivational interviewing platform. And so this is more transitioning into recognition that we ourselves all have stigma. I've worked with drugs of abuse as a primary area of research of interest for well over a decade now. And it really hasn't been until I've been in the addiction clinic and writing and managing this that I've noticed myself, and I picked up things that I do, and I know I still have some areas of stigma or things that I underappreciated. I always appreciated when people point those out on me. Those of you who've heard me talk, and when I say I've learned more from my patients in the realm of addiction, I'm not kidding. I really have, and a lot of it, my patients have taught me a lot about myself. And if I'm ever having a bad day, my patients always seem to be there to help me out, and listening to their stories and to see how bad they had it in their life and where they are now. And to knowing that my life, I'm not at their rock bottom or anywhere near that. And I'm really helps always put a recognition on how grateful that my life is. So take a little bit of time to just to be able to communicate and to listen to your patients, and they will help you communicate better with people. We have our peer support people, and a shout out to them on the call. At Presbyterian, I'm at UNM across the street, and my hat's off to you and the Presbyterian crew. You guys are far ahead of us at UNM on an addiction standpoint, so thank you for that, and thank you for all your work. The peers also help a lot with, they have taught me and made me think of substance use problems the way that I had never thought of it. I still make the final decision based on medical and the science, but again, they're a wealth of information. So I think this is just getting into a series of slides that I want to quickly kind of go through, and that we know the goal here is to retain people into treatment, and we want sustained, we want long-term recovery. And if they need to be on medications for a long period of time, so be it. The studies that have been done to date go out to a year, maintaining and people coming off within a year, very, very high relapse rates and things. Again, we want to set our patients up for success, and we want to set them up sustained success. We do have a clinical trial. Contact myself, Dr. Jacobson, Dr. Bott. If you have a patient who expresses interest in coming off of buprenorphine or naltrexone and are stable on it for a year or more, and my wording, I'm very careful on this, is if the patient is expressing, I don't want anybody going out asking or encouraging patients to come off, as that would be an IRB or an ethics violation on our end. But we have a couple of study protocols where we're weaning people off and trying to see if we can do that. I also want to try to highlight some of the work that we in New Mexico do, just because we have such a high rate of opioid use disorder. We're an underserved state, and we've gotten the attention at federal levels, and want to make sure that our patients are well represented in those studies as well. I guess with usual patterns of remission, this is an area too that becomes important to maintain recovery. And are we asking the question, who else in the house or in the home uses? Who else do they spend significant time with that uses? And are those people interested in getting help? Because sending a pregnant woman back into a house with their significant other who's still using is a recipe for relapse, and we want to try to help our pregnant mothers out as much as we can to do, and to use those as opportunities where we're bringing people into care and providing care. Factors associated with remission, medication, treatments. I apologize, probably a more updated or current national wording with medications for opioid use disorder. And the distinction is important because we know medications don't assist in therapy. Medications are the cornerstone of it. Not detoxifying our patients all at once, and making sure that we help them in sustained recovery. We continue to get continued pushback over the years on people who have achieved sobriety through just willpower alone. Again, my hat is off to them. I have a lot of respect for those people. And most importantly, congratulations, you're in recovery. I'm trying to get a whole lot more people into recovery just where you are. And the science is overwhelming that medications really help us with opioids. And so let's all work together on getting people into recovery. How to maintain recovery. I think it's really important giving people hope. Hope is so important to who we are as a person. I feel like I'm stuck on pregnancy today, but as a man, I can't imagine the pain of giving natural childbirth and looking forward to, there's an end in sight to the pain that comes with childbirth. And at the end of it, we're going to have a wonderful, happy child that we grow and raise. I think with our patients who have a substance use disorder, giving them hope that their life does not need to be one where they're living in the shadows of the world, and that they're here. I know with our peers on the chat here, always a big shout out to you guys for being willing to share your story and to putting your story to your motivation. And a shout out to Athena Huckabee, who we tend to work a lot together and see it a lot, who's in recovery herself and has used that to help many, many people and make the world a better place. Those are, and people seeing, and I'm going to pick on Athena because I know her, and she's here to defend herself. But I think, when you see Athena working and speaking publicly on these issues, she's well educated, she's bright, and she doesn't come across as a dearth of the earth. person, but is a happy, friendly person that you want to be around. These are what people in recovery look like. And I think it's important to have people like that showing hope for patients still in those places. And again, recovery is a really important part of health. We talked about the HIV, hepatitis, bloodborne pathogen transmission, other diseases that are transmitted with individuals, and just the mental health alone that is improving. Also, a big remembering that a lot of people with a substance use disorder have children too, and that they're trying to raise children in this environment. And those of you working with abuse and intimate partner violence, substance use is so pervasive, 80-90+% is there. And if we could eliminate the substance use disorder in our state, it would be the single biggest thing that we could do to decrease child abuse here. And we've certainly seen child abuse go up dramatically during COVID. So I know I'm at 12:30. I got through a lot of the most important slides. I have several